is a continuation of chapter 32 to go over OB. So this part is going to cover delivery complications. So common types of complications associated with delivery would be things like the umbilical cord wrapped around the neck, the unbroken amniotic sac where the baby comes out still in that sac, full of fluid, kind of a Alien vs. Predator style, kind of weird looking thing, and the infants who need encouragement to breathe so that baby doesn't come out, isn't crying, screaming that they're cold. They came out of their nice warm house, now they're out in the cold air. Those patients, those little baby patients that need a little bit of stimuli. A breech presentation is basically a baby that comes out in a different way than it should. The baby should come out head first. So if there's anything coming out first besides the head, that is a breech delivery, whether it's legs, the butt, the feet, whatever's coming out. With those types of deliveries, a major concern is meconium staining. Okay, so the meconium, what that is when the baby's in the amniotic sac, that if it gets into stress, or even just sometimes in more minor cases, the baby can actually have a bowel movement. So that meconium is that first part of the bowel movement that happens. So the baby's in that sac and can possibly aspirate its own meconium. So if you see any baby coming out with greenish, brownish stuff smeared on it, that's meconium. So as you see here in this lovely illustration, this would be a breech delivery to where the feet are coming out first. So with those limb presentations, most common type of a breech delivery would be feet first. That's going to mean that you just need to rapidly transport to the hospital. This could mean that the baby's in major distress when those feet are coming out first. So we're not going to try to encourage the mother to push this baby out. Give them a comfortable position and transport rapidly. So you can see here in this picture of the breech presentation with the limbs. So feet hanging out one way or the arm out the other. A lot of times in these kind of deliveries, they're going to end up being a C-section delivery. They'll go in and do surgery, open up the mom, and pull the baby out through the belly. With that prolapsed umbilical cord, that means umbilical cord is coming out first. So that the cord can actually end up being compressed between the vaginal wall and that baby's head. So remember, that umbilical cord is a supply to the baby. So the supply of blood, oxygen, nutrients, everything from the mom to that baby. So just imagine what happens if that head of the baby is pressing against that umbilical cord that's hanging out of the vagina. So if it's pressed against it and there's no pulse in it, that means there's no blood or no circulation getting to the baby. Major issues there. So with that prolapsed umbilical cord, this one thing's going to have to get a little bit more serious. So you need to get the mother uprighted, get the butt up in the air to kind of help take the pressure off of that cervix, trying to prevent that baby from coming out. Then you're going to have to take a gloved hand and insert it into the vagina to lift that head up off of the cord until you can restore circulation in that umbilical cord. And once you do that, that is where you stay the entire transport. So your entire transport will be spent with your gloved hand in the vagina of the patient, supporting that head, keeping it up off the umbilical cord until you can get them to an appropriate facility. Multiple births. Hopefully, mother has obtained prenatal care to where she knows how many babies are inside. Even with that, there are still medical flukes to where sometimes they don't know how many babies are in there, but those are those 1 in a million chances. So if there are multiple births, you're going to have a big concern here that you're going to have multiple patients. This is now going to be an MCI event because you're going to have a couple care providers and a few babies. So making sure you have enough resources to deliver this baby, knowing that you've got enough OB labor and delivery kits, that you're going to have enough clamps, that you're going to have enough hands to be handling all of these babies. So if it's going to be imminent delivery, you need to be sure that you're getting plenty of help on the way. With premature delivery, that means the baby has not reached its full gestational period. So anything before 37 weeks is considered premature. So premature babies, I'm sure everybody knows, sometimes have a lot of health issues. So you're going to have to work very hard to maintain the life of this baby. So premature birth, big things, always keeping the baby warm, keeping that airway clear. If need be, provide CPR if you have to. Be checking that umbilical cord, avoid contamination. Because with these little ones, their lungs, nothing is developed yet, so try to keep them as clean and as sterile as possible, and call with sufficient time to the emergency department. Let them know that you're coming in with a premature birth. Now, as I said before, with meconium, that's that greenish and brownish, yellowish color stuff that when the baby may have a bowel movement. If you see meconium staining all over the face, be sure that you've provided enough suctioning before you stimulate that infant. If you stimulate them, the first thing they're going to do is take a deep breath through their mouth. And if they have a mouthful of meconium, they could possibly aspirate that. So be sure to suction out first. So as the head is coming out, you always need to suction that mouth first, then the nose. We're not trying to teach these little kids to be booger pickers yet. So suction the mouth before the nose. Making sure you're keeping that airway patent with those is so important. And then if need be, provide ventilations or chest compressions and transport as soon as you can. Meconium aspiration is a very fearful thing and can make little kids very sick, if not sometimes be fatal. Excessive pre-birth bleeding is a very serious issue. This can cause a patient to develop hypovolemic shock from the major hemorrhage. So always assess them for shock, supporting their ABCs, and try to control the bleeding. Now don't pack things up in there. Just place sanitary napkins or vagina. If the patient has any maxi pads, anything like that, they can use that, or you can use your multi-trauma dressings or abdominal pads, anything. All that tissue that's used, make sure that you're putting that in a bag, because the doctors are going to want to see that to try to estimate how much blood they may have lost. One of the most difficult things about this is excessive pre-birth bleeding is oftentimes associated with labor issues. Such issues could be a miscarriage, whether they just didn't go to full gestation. Generally with those, it's light bleeding, nothing too excessive, and that's early in generally the second trimester, but the excessive bleeding can be caused by the two things dislodging with the placenta, either abruptio placentae, which means that where the placenta is normally attached to the uterus, it's basically ripped off of it, or the placenta previa, where the placenta is supposed to be towards the feet of the baby or superior in the anatomical plane of the uterus, it is now inferior. So the placenta could cover up the cervix completely, impeding the complete delivery of the kid. So hopefully the parent has received prenatal care and they know these conditions. I've known of several people in the past who've had these issues, and say in instance of abrupto placenta, they're put on complete bed rest. And if they know they have placenta previa, they know that they're going to have the baby via C-section, and are fully aware of this, and they know the conditions, and they've went on to have successful deliveries, generally C-sections, but always had good successful deliveries and good healthy babies. An ectopic pregnancy basically means that the fetus is starting to develop in places that it shouldn't. Any female who is of childbearing age, so generally even 12 years or older, who has lower flank pain or lower quadrant pain, so that right lower quadrant or left lower quadrant, if they have pain there and they're of childbearing age, very good chances it's an ectopic pregnancy. So always ask if they are sexually active. If they are, there's a chance they're pregnant. So if they say there's no chance they're pregnant, but they admit that they are having sex, it means it could be ectopic pregnancy. So assessing for bleeding, those lower quadrant abdominal pains on rapid pulses, low blood pressure, because they could be bleeding a little bit, just making sure they're not in shock. So every childbearing patient with lower quadrant pain, ectopic pregnancy until proven otherwise. In pregnancy, there is a condition called preeclampsia. Basically, this means that the patient has really high blood pressure. It's causing excessive weight gain, swelling the face, hands, feet, everywhere, more so than normal. So preeclampsia means that the patient's blood pressure is very high. Whenever the patient has developed full eclampsia, that means that they have had seizures due to that extremely high blood pressure. Now, how high is high varies between physicians, but sometimes a patient with a systolic pressure of 140 is considered high, whereas other physicians will let it go to systolic of 180. Once you're hitting up around over that 180, very high chances of causing major vessel diseases and seizures and various other serious medical conditions. Miscarriages and abortions. Abortion isn't always something that happens in a doctor's office and is a topic of controversy, but it is something that can just happen spontaneously or it can be induced. Say, a miscarriage or an abortion could be caused from trauma, different things. So generally, the patient has cramping, abdominal pains, and vaginal bleeding and discharge. With a stillbirth, one of the hardest things that's going to be in your job is providing comfort and sympathy to the patient, the mother. So if you see a stillbirth come out and it's way before the due date and you see obvious death, do not resuscitate if there's obvious signs of death. Don't make it any more traumatic on them. Big thing just going to be providing comfort for the mother and life support and emotional support for the mother. In trauma patients, an indicator that a patient is in compensated shock is their breathing rate goes up and their heart rate goes up. But with pregnant trauma patients, that can just normally be the signs and symptoms given. So since they do have to supply blood for themselves and that newly developing fetus, their heart rate's going to go up and their body holds and stores more blood. Since they got to supply blood to the body will create an additional source of blood for that fetus too. So the blood volume of that pregnant patient increases. So their pulse rate will be higher and their blood volume is going to be higher. So a trauma patient may experience or may be able to sustain higher amounts of blood loss than the non-pregnant patient before the shock in that patient becomes bad. If the patient goes into cardiac arrest, there's still chances of saving that unborn child. So you need to begin CPR immediately. Even if the signs and symptoms of that mother are significantly bad, you don't think you're going to save her, you need to begin CPR on the mother, because if there's no heartbeat in the mother, there's no blood circulation to that fetus. So if the patient is significantly pregnant, more than 20 weeks, get them elevated or set to their left side. That'll displace the fetus off that blood supply of that blood return of the inferior vena cava. Because if we're laying on the back, that big belly and the big baby can lay on that inferior vena cava and reduce blood return. So displace that uterus to the side, put some padding under the right butt cheek, get it shifted to the side, and begin CPR. Since they do have that big belly, you're going to have to put your hands generally a little bit higher up on the sternum, more so in that lower half of the breastbone, because the belly is going to be sticking out there. So you continue CPR all the way to the hospital. This isn't an arrest that you work at the house. You start CPR, continue compressions on the way to the hospital, so that blood supply is still circulating to the mother and to that fetus. CPR will continue until the patient has an emergency C-section to try to remove that baby. Vaginal bleeding is always a bad sign, unless it is just that typical time of the month for the patient, and the typical kind of bleeding. So otherwise, any kind of bleeding like that, you're going to treat as potentially life-threatening. Checking for other associated things such as abdominal pain, checking the signs and symptoms for shock of tachycardia, hypotension, pale, cool, diaphoretic skin. If there's ever trauma to the genitalia, you may have to go and examine it, whether this be trauma from vehicle accidents, slips, trips, falls, other severe cases such as rape. You may have to go and examine everything. If you do see significant bleeding, pad it, don't pack it. So you don't need to be stuffing stuff in there. Just pad it with an abdominal dressing, a multi-trauma dressing, anything to absorb the blood. And anytime you absorb blood with genitalia damage, always make sure you're keeping those, because the hospitals will want to estimate the blood loss. In cases of sexual assault, you need to be emotionally supportive. Be understanding. Don't try to do interrogations, and don't judge. This is a crime, so you will have to treat everything, including the patient, as a crime scene. So generally discourage them from bathing or cleansing any kind of wounds, because there's DNA evidence in that. Any of the kind of clothes they may have, be careful using those. If you're having to cut the clothes off, then be careful of where you're cutting, to where if there is any trauma, stab wounds, anything like that. If there's a cuts, holes, anything to close, and you have to cut, try to cut around those the best that you can. Always be very lengthy and detailed in the reports that you write, in case you would be subpoenaed to go to court later on down the road.